We have around 20 minutes for questions, and we have colleagues with microphones at the back. Colleagues with microphones, can you give us a wave? Hiya. If you can't see them, they've got those high-vis on. So if you have a question, could you please put your hand up and let us know who it is directed to or to the panel as a whole? We have a question at the front over here.
Oh, hi, and thank you all so very much for all your interesting talks. My question, or well, what I'd like to put this to in some way is to Professor Birks, I think, who was talking about the social care system. And I wonder if there is any more emphasis, because it wasn't talked on there, of families providing more care, as they do in other countries. It's very strange that in Britain, although there are families who do this, and not taking away from them at all, but the emphasis isn't on children looking after their parents, for example, as there is perhaps in Asian countries and other countries as well. And I wonder if there was more support put in for the families, direct support, and more social hubs for elderly people to go to that would alleviate the pressure on those families, whether more could be put into that.
Thank you.
Okay, yes, yeah, thank you. I mean, I think that's a really well-observed point. I mean, I think families give a lot of care in this country, huge amounts of care actually, and they're quite hidden, often the carers. There is some support for care, but it's a separate process to access it, and there aren't. If you think about how much it would cost for somebody who had no family to receive the kind of care they get from a family member, those family members get very, very little money actually to support that. And I certainly agree these kind of social hubs are a fantastic resource, and I think what was difficult in COVID is a lot of those shut down. So I think COVID shone a real light actually on how much families were doing, because what happened is all of that went. So none of those resources were available, and a lot of them shut down. They're often run by the third sector. There used to be, certainly I can think a few years ago, you might have paid £20 or £30 for someone to go for a day to a day centre. You're probably talking nearer £100 now. It's still a lot of money. So I know that some of the thinking around how we support people, not just older people, but actually anyone who needs social care support, is often focused around what assets do we have in the community that people could use, and helping people work through what's available. But sometimes people have problems with, if they're very isolated and lonely, that they need someone to go along with them in the first instance so that they can feel more comfortable, and that's an expense and a resource in itself. So I think there are lots of really good ideas and lots of solutions out there that work for some people but not everyone. So I think some of this is about having the resources and the time to sit down with individuals and talk through what might be the best solution for them, and signpost people. But that takes time, and I think local authorities are really struggling with having enough people to signpost to that. So they tend to focus on getting people out of hospital, or people who don't have anyone to support them in their family. Obviously there are a lot of people ageing without children, or who for whatever reason aren't in contact with their families. So it's a really complicated picture, but I agree with you. It would be really good if we could use resources to take some of the pressures off people who are caring for relatives, and a lot of people do. Does that answer your question?
Yes, slightly it does. Yes.
Oh, okay. Well, I'm happy to talk to you afterwards.
Thank you, Yvonne. Further questions? In the middle, down at the front. And then we also have one over there after this question. Thank you.
Thank you, and thank you for the stimulating talks. I guess the question for all of you is about finding your most effective partners in order that you can deliver the impact from your research. But I guess I wonder if I could start by directing a question at Yvonne, because you talked about the difficulty of the fact that you have a large private sector part in social care as well as the public sector, and I guess what's triggered the question is that sounds like a particularly difficult environment to find the effective partners to have a wide-scale impact. So I guess I'm starting with that, but it's a broader piece for everyone.
So yes, it is. But I would say that actually in the private sector, because they are selling services to some extent, they are slightly more motivated to look for research solutions. So they, of all the workforces, actually often have an unregistered workforce, but the managers in those environments, I think, are really committed to research. They're just not sure how to bridge that. I think local authorities are so busy and so overwhelmed that they really struggle to engage with research, which is why we're focusing on local authorities at the moment. But yeah, it's a really big market for care, and so we need to have lots of different ways of working with lots of different partners.
Thank you. Adele, I don't know if you want to pick up that question of finding the right partners and good ways of working with them.
Yeah, so I mean, we hitherto have been fairly fortunate in the UK. I guess if I focus on being able to do clinical trials, we've had pretty good structures in order to do that. And the major partner, of course, is the health service, and that has been a massive bonus in the UK's ability to do this. And the UK has generally, in the past, been one of the leaders in conducting clinical trials for two reasons. One, because of the NHS, and because there's a legal basis that the NHS is supposed to participate in research, and there is funding set aside for that, although it's not always easy to persuade individual hospitals. And also because we have such a strict process for approving drugs, people can't get drugs unless they've been through certain categories. So I think people are more willing, and also we've had a population who generally seem very willing to help us answer questions, even if it's not going to benefit them. So I think we've been, in the area that I've been working in, we've been very fortunate because we have the NHS and the public as willing partners, and I think we've managed to succeed quite well on that basis.
Amazing, thank you, Adele. And Clara, you said you had too many partners to thank at the end of your slide, so you've really walked into this one. Interested on views of your working with partnerships experiences, where it has worked really well.
Oh, goodness. So I suppose from a purely research, because I'm not a clinician, I'm not clinically qualified, but over the years, I think the best advice I could give, if anybody wants to do interdisciplinary or kind of multinational collaborations, is don't be shy. Reach out to people you find their research really, really interesting. Email them and ask if they have capacity. Most people I find are really, really welcoming, and most people jump on the chance on doing a bit more with different people with different countries. So especially in terms of my experience with the hallucination consortium, which consists of, I think, hundreds of people from all around the globe. The first step is to reach out. And I have worked also with hospitals and NHS partners, and my advice is the same, is to reach out to the R&D department, to actively talk to them at events, conferences, just build a network. Yeah, that's how I ended up with hundreds of collaborators.
Thank you, Clara. And Nadia, I mean, you have the best partners of all, of course, of our students. Two questions from me. How would you find out? And I suppose the selfish one that I was interested in, would you expect to find the same results you found in research at a different university? Or do you have any inklings of what that experience is like outside of York?
Yeah, so in terms of finding partners, I mean, I talk to people about my research, and typically you find that people who have had some sort of international experience, whether that be colleagues or other students, just kind of like want to work on the project because it really resonates with them on a personal level. And so the research that we conducted, only some of the students came from York, really. I mean, about half of the students came from universities across the UK.
Amazing. Thank you all. We had a question at the back over there. And just over there. Thank you.
Hello, thank you. My question is for Dr. Jessop. I volunteer with an organisation which seeks to welcome international students to York. And I just wonder, as an older person, can you give me any hints and the easiest ways that I can support international students who are here maybe for short term or slightly longer term, maybe doing PhDs? Yeah, thank you.
Yeah, so that's a really good question. I think some of the most insightful information that we got from the study was based on those qualitative responses. And so what students were kind of pointing at were the depth of interaction, so having meaningful interactions, so not just hey, hi, how are you going, but having someone to show that they actually care about them and care about learning about their culture, so that they feel that they are able to share that part of themselves that will otherwise have to stay, you know, a bit quiet when everybody around and the majority of people are British home students. So I think really going for those meaningful interactions, trying to learn a bit more about the student and their background and their culture will probably go a very long way.
I really like your slide, Nadia, where it's talking about the student quote saying, I really like when people treat me like everybody else.
Yes.
I thought that was a really, really powerful example. Thank you for that question. Oh, we've got a flurry of hands. Maybe go left. Actually, yeah, let's go left, and then there's some over there after this question. Yeah, just there.
Right, thank you for the fascinating talks. Question for Professor Fielding. I mean, you commented in the past the UK healthcare ranked well internationally. How would you rank it today, and what's the direction of travel?
Okay. Well, I mean, I have to watch it, you know, what I'm going to say in case I upset anybody. But I think things are not great at the moment, you know. I'm currently doing my clinical work at Castle Hill Hospital in Hull, and I previously did my clinical work in a big hospital in London. And there are just enormous pressures due to insufficient staff is probably the biggest issue. And I think one of the bigger issues from my point of view is no longer being part of the new European Medicines Agency, because we now, for any company that wants to get a new drug approved, they'll go to the EMA and the FDA first, because they're huge regulatory bodies that represent enormous numbers of people. And so the UK, the MHRA, you know, has lost a lot of power, because we used to be a leading light in the European Medicines Agency. It used to be based in London, and it was pretty much run by. So I think there's going to be some problems in the longer term now with when new agents become available. The UK is not going to be the first market that companies go to, and I think that was a incredibly short-sighted decision to have made that. Whether you believe we should or should not have left the EU, we should have done everything we could to remain in that regulatory harmonisation. So I think that's going to be a problem, and I think people are just fatigued. I think a lot of what happened during COVID is very, very traumatic for clinicians working at all levels in hospitals, in general practice and so forth. And I don't think the staff are really well treated or well looked after anymore. We talk about it, you know, from the olden days. Like I remember when I was first qualified as a junior doctor, you know, when you would do your nights on call, you got a room. So if you couldn't afford to get yourself a place to live, at least a hospital provided you. It was a bit grubby, but it was a room you could stay in. But all that's completely disappeared now. So there's just vast amounts of support that used to be given to staff that's eroded, not just for doctors, but for nurses and all type of NHS staff. So I don't feel great about the situation at the moment. And I know the only shining light is that I've colleagues work you know, indefatigably to try and plug these gaps. But I'm worried that a lot of emphasis now on individual responsibility to try and shore up a failing service, and, you know, individuals are getting really tired. So I am, not super happy about the situation right now.
Thank you, Adele. And Clara, until I saw your speech today, I knew very little about schizophrenia. I'd be interested in what the availability of clinical professional services is for people who have schizophrenia. Is it widely available, difficult to access, challenging?
So as far as I know, if somebody has a first psychotic breakdown or a psychotic episode, they're usually referred to, not in all cases, luck, to early intervention for psychosis services, which is usually the first stop of kind of integrated care for people who have this, not necessarily schizophrenia, because that diagnosis usually doesn't come until many years later. So the early intervention services are usually really, really good, and I keep saying usually. But in some areas, it's a bit of a lottery and it's pot luck whether you end up with really good care or really, really bad care. And what is really unfortunate is this first impression of people often leave the patients either really, really engaged with further treatment, with their community mental health nurses, with the care coordinators, psychiatrists, or they just don't want anything to do with the mental health services ever again.
Right.
So it's very much hit or miss, and it's accessible as far as I know, but there are waiting lists, again, depending on the region you're from or where you live. It's a postcode lottery for many people.
Thank you, Clara. We had 2 further questions in the audience over that side. If we go at the front and then one behind.
Hi, thanks for all the speakers' interesting talks. And my question is for Dr. Jessop. I'm really impressive about what you have did in your research. So your research basically explores the inclusion experience amongst the international students and how it impacts their educational performance. I wonder why, if the same effects will be placed on their sustainable performance, especially in their transient living in the UK. And also, I'm wondering for higher education sector, whether we can perceive students' cultural diversity also as an asset. So how we foster them to bring the good practice in their culture to foster the sustainable practice and enhance the performance when they live and study in the UK. So this is my question.
Well, quite a multi-pronged question. So I think one thing I can say, so we do in our department often think about our international students, not just how well they're doing while they're with us, but also how they're transitioning after they graduate and go on to the world of work. And so I think the point that you raised about valuing the assets that international students bring to the university community and to the wider community is a really big factor. So I think to the beginning of my presentation, I talked about some statistics about the monetary value that students bring, but I like that in your question, you kind of highlight that there's also a cultural value. So this idea of cultural exchange and how that diversity can enrich the experiences, not just of the students, but everyone that they interact with. So I'll take that on as a good point, just something to focus more on as I go forward with this research. So thank you for that comment.
Thank you. Behind.
It's a question about blood research into leukemia. Do you have a hypothesis why younger people tend to recover and older don't? And any research results indicating why?
Yeah, so that question is very timely and very interesting. So thank you for it. So it's noteworthy, I think, that if you look at the incidence of the disease that I look at, which is acute lymphoblastic leukemia, there's a peak incidence at the age of 10, and thereafter it drops. It's lowest in adolescence, and then it slowly rises to reach a second but lesser peak in older age. And I think that says something probably about how leukemia develops. So we know that in childhood leukemia, at least a proportion of children who have ALL have had the first genetic hit in utero. So there have been twin studies from many years ago that have demonstrated, because you can look at Guthrie spots, which are the little heel prick that everybody gets done. You can go back and actually detect the mutations that are present in the leukemia that, you know, had been present at birth. So I think they're probably, although they come out in the patient as the same disease, they're probably almost potentially two different diseases, adult and childhood ALL, but they manifest in the same way with the same cells affected. So that's the first thing. And so if you look at this spectrum of genetic lesions that are present in childhood versus adult ALL, there's some overlap, but there's a huge difference. So there's some genetic lesions that underpin 30 to 50% of childhood ALL, and they're completely different from the ones that underpin that amount of adult ALL. So we know that. We also know that the sort of aggressive chemotherapy that's mostly currently used in treatment is much better tolerated, if you like, by children. Tolerated, all being is grotesque, but, you know, so that's another thing. But what we don't truly know is why certain genetic lesions we know they're associated with a worse outcome and they're more predominant in adults, but we don't know why. So actually that's something that I am personally working on. So my working hypothesis is it's to do with the way the bone marrow interacts with the leukemia cells, not just the leukemia cells itself, but the spectrum of help they get from all the other associated cells in the marrow. And what we've seen in some of work that I've been involved in doing in my lab is that certain genetic lesions are more likely to stimulate and subvert the cells around them in the bone marrow to give more help. And those lesions are more common in adults than children. So I guess that's the working hypothesis, and something that we're interested in really is because the cells, cancer of any kind doesn't really survive in isolation. It's in a tissue, it's surrounded by cells that help. So that's kind of where we're going, but it's obviously probably a multifactorial thing, but a subject of active research in my lab.
Adele, thank you. Right, we're at time. An hour and a half, the length of a football match, gone completely in the blink of an eye. And being a Newcastle fan, it's gone much quicker than some matches I have seen in my time. I mean, so much more we could have gone through. I mean, Adele, I'd be fascinated on how we pitch clinical scientists, why people should become them. Nadia, what you'd expect outside of York and adaptation to different educational settings. Yvonne, why we just can't politically solve social care and get at the top of the agenda. Clara, why the stigma is so persistent. I've got an enormous amount of things, but we're at time. The last thing from me is to say thank you very much to our wonderful panellists. Thank you so much for being a wonderful audience, and thank you very much to the University of York for facilitating such a wonderful set of events. Thank you all very much.